Okay, in this session we're going to go over some of the basic ethical approaches or ethical dilemmas that you're going to face in dealing with patients with kidney failure. Again, I won't go into a great depth on kidney failure. For those of you that aren't a nurse or a physician or don't have a lot of clinical knowledge, again, I think you can get enough of an idea for the purposes of this course if you do Wikipedia search and read that, or WebMD or something like this, a basic resource on kidney failure. The challenge for those of you that aren't nurses or physicians in doing clinical ethics is gaining enough understanding of the medical phenomena, of the medical circumstances, to really be able to grapple with the ethical dilemmas. Again, in my early lectures, that's what I had tried to point out, that it's often the physician or nurse, those that are engaged clinically, that I think can do, generally, there's exceptions to the rule, often they can do a better job at clinical medical ethics, in that they can learn enough of the ethical approach to know how to grapple with these things. And they know the clinical phenomena well, where they don't create false dilemmas. Probably the best skill is to have an effective communicator. If you're a good communicator, regardless of the discipline one's coming from, you probably have the skill, one of the most essential competencies for a clinical ethicist. So, but in this session, we'll focus on addressing the patient with kidney failure. Kidney failure is very common. The most common causes of kidney failure are diabetes mellitus, so having high blood sugar, or hypertension, having high blood pressure. There are also a host of other kidney ailments. Some of them are autoimmune, or some of them are just kidney disease that happens just in the kidney. Sometimes when people have undergone cardiopulmonary arrest, or if they've gotten so sick from an infection and they have sepsis, which this is systemic inflammation that can lower one's blood pressure, so in septic shock, the kidneys can be damaged from a lack of blood flow. The kidneys are basically a bundle of blood vessels, and when there's low blood pressure or low blood flow to the kidneys, they can often fail. Sometimes that's temporary, sometimes that's ongoing. So kidney failure we can think about as acute kidney failure, that is, that it happens all of a sudden, and chronic kidney failure. Often the treatment for acute kidney failure is to try to treat the underlying cause. In the case of someone who has an infection and is in septic shock, you try to treat the infection. And the main treatment for the kidney failure often is getting fluids and blood pressure enough to help the kidneys recover. Occasionally, in acute kidney failure, patients may be put on a machine called hemodialysis machine. Hemodialysis is a machine that cleanses the blood from various toxins and also brings fluid off. This is key. So this is overly simplistic, but hemodialysis, or dialysis in general, works at trying to clear toxins from the blood. And some of these toxins really aren't toxins. They're things like electrolytes, things like potassium, things like things that help with your acid, your acid base status, and other chemicals. And then it also helps with fluid management. So people, when their kidneys have failed, can have a buildup of fluid, and dialysis can help bring some of that fluid off. In acute kidney failure, sometimes that's a challenge, in that bringing fluid off is often you're giving a lot of fluid to keep the kidneys happy. But that's going further than that will be beyond the needs for this short session. In chronic kidney failure, we are also talking about something that often leads to hemodialysis and the removal of toxins and the removal of fluid. Chronic kidney failure, like I said, is mainly related to diabetes mellitus or high blood pressure, hypertension. Sometimes is also related to autoimmune diseases and other diseases as well. We won't go into all the various types. Hemodialysis is in the history of the world, a fairly new technology. You'll hear a little bit about the history of hemodialysis if you watch the supplemental film, the documentary on the God Committee. But hemodialysis came about in the mid-20th century. The first hemodialysis machines looked like big washing machines. Partly, I think they may have been big washing machines at the base of them. They use the way they work is sending fluid through a machine and sending blood through the machine, and there's a membrane, a semi-permeable membrane between the blood and the fluid, and depending on what you have in the fluid that's going through the machine, it will draw across that semi-permeable membrane some of the various elements out of the blood and into the fluid. So if you have a patient with high potassium and you're trying to get that potassium to go across into the fluid, so you have blood and you have the fluid, the fluid's called dialysate, and you're wanting to go this way, you would have a low potassium fluid bath, and you'd have high potassium in the blood. And if that's the case, you'll get this natural flow between the two. That's the basics. How to draw fluid off is more complex, but we won't go into this, but you get the idea. It cleanses the blood. Now, there are other types of treatment for chronic kidney failure that are other types of dialysis and then transplantation. So hemodialysis requires an access to large blood vessels. So you can't do hemodialysis through a small peripheral IV like what we use to give medications. It needs to be a large IV, so it's somewhere in the central vasculature, or there is something called a fistula or a graft. So these fistulas or grafts are surgical procedures where there's a connection between the arterial and venous supply or blood vessels. If at the graft, it's a man-made item that's put in. Fistula is when they take a vein and connect it to the arterial flow, and over time that vein changes its properties so it becomes more muscular and stronger and can take pokes of needles more frequently. So there is an ability to receive hemodialysis by sticking needles in the arm, but it's not in the normal blood vessels. It's in blood vessels that have been modified through either a formation of a fistula or graft. There also are some people receive hemodialysis through large bore IVs that are put in one of the main blood vessels, either in their groin or in their shoulders, neck, not shoulders, but in the chest, upper chest. These are seen as problematic only in that they can become infected. To have a large IV in, the body's immune system doesn't clear bacteria from foreign bodies as well as it does our own body. So having an IV catheter sitting at the edge of someone's heart, the entrance to the heart, can lead to really catastrophic infection if it's there too long. These are similar but different to the kinds of ports that are placed for chemotherapy. Those that have skin overlay and are getting accessed by much smaller needles are a bit safer than these large bore IVs that have a large external component to them. So fistulas and grafts are considered safer, decrease infection, and are needed for getting the access. Patients on hemodialysis, which is hemo is blood, so blood dialysis, will generally get dialysis. The current standard is 3 days per week. So it's not trivial. What this entails is going to a dialysis center. In most cities in the United States will have a dialysis center in most neighborhoods. Not small neighborhoods, but in at least every suburban town there will probably be a dialysis center. And so it's usually readily available. Some small rural areas won't have them, but most towns within rural America that are sizable enough will have them, just because we have so many patients on hemodialysis. So it requires 3 days a week. Generally, it takes well over an hour, often over 2 hours of dialysis time. Sometimes it can take even longer, depending on what the flow rate is, what the patient's needs are. So dialysis can be quite a just time burden in accessing the medical system. The dialysis is generally covered by Medicare. I'll tell the story again with the God Committee video, but Medicare, at the beginning of dialysis, there was this great drama on the U.S. Congress floor as a congressman brings a kidney failure patient out and says, if we don't pass this Medicare spending bill that covers all dialysis patients, all kidney failure patients to get Medicare, then this patient will die. And it passed. The projections that they had at the time of how many people would actually need dialysis, how many people would actually have kidney failure, was much lower than what's been realized. We can speculate that if they knew then what we know now, they may not have approved it at the time. I'm not saying it was the wrong decision. It was just an expensive decision. And you can look up the amount of money spent on dialysis and kidney failure every year through Medicare. Medicare, of course, is only available if one is in the country legally. So those who are in the country illegally are not eligible for Medicare, Medicaid services. I keep changing markers because I don't like the way any of these look. So one of the issues that we'll talk about is undocumented workers or undocumented residents and their legal status. But more about just the basics. So if someone is diagnosed with end-stage kidney disease, so chronic kidney failure, if you have chronic kidney failure but it's not quite, your kidneys are still working, it may influence what medications you can get, or some therapeutic studies you can't get, or they have to be modified in some way. But it's when someone is in stage kidney disease or in stage renal failure, these are these definitions in the alphabet soup of medicine, that they become Medicare eligible if they're legal citizens of the U.S. Sometimes they may go on disability as well from this, not always. So kidney failure and end-stage kidney failure doesn't automatically bring disability. It brings a special Medicare status. And so it doesn't take full disability. It's filling out special forms saying that you have end-stage kidney disease. The Medicaid sometimes also covers certain aspects, but most people that would qualify for Medicaid would automatically qualify for Medicare. So my point here is that it's funded. As long as someone has some sort of Medicare eligibility. But this 3 days a week is a big deal. The natural history of disease, what patients die from that have kidney failure, they may die from their kidney failure. And prior to the era of dialysis and kidney transplantation, patients did just die from their kidney failure. And they still do. However, if they're placed on hemodialysis, the most common, if you take the common kidney failure patient that has kidney failure from diabetes and high blood pressure, their average life expectancy is, at least in older data, suggested about 5 to 7 years. It may be getting longer now. Dialysis has improved. The problem with all these numbers is it really depends on which population you look at. If you're the main category here is the patients with diabetes and hypertension, high blood pressure, so that they die from stroke and heart disease. So patients with kidney failure, if their vascular disease, the blood vessel disease has gotten so bad from their diabetes and high blood pressure that they get kidney failure, then they probably also have blood vessel disease in their heart and their brain. And this is what they often will die of. And if you remember from the brain failure, this is a major issue. All right? So this becomes another question that we have to deal with, is what do we do with the neurologic failure patients in dialysis? Heart disease is a little less complicated. Other patients who don't, especially those that don't have high blood pressure and diabetes, that's not the cause of their kidney failure, often will live a lot longer. And sometimes then it becomes an issue of vascular access. That maybe due to repeated infection, it may be difficult to find vascular access to be able to care for them. And sometimes there's even, surgeons get very creative in trying to find some way of getting a superficial vessel, a large enough superficial vessel or a graft that's large enough, able to access with the needle to or port to be on dialysis. So you will have occasional patients who will die because they can't be dialyzed because you can't get a good vascular access. Some of these patients have other social challenges. So they may not have, they may be non-adherent to medical advice, and they may come in and out of the hospital and not be able to ever get that good fistula in advance or that good graft, and they're just getting different central venous catheters, these large IV catheters, and over time those can get infected, and it can really do damage to the blood vessels. Sometimes they may have IV drug abuse, and then you have a whole different category of issues as having a patient leave the hospital with vascular access when we know that they're going to go and use that for IV drugs. Most clinicians and most clinical ethicists regard that as a non-option, that we must come up with an alternative to this. So that's really the most common person that falls into is more covered in a special type of heart failure. I'll probably cover it here just briefly because sometimes it happens to certain dialysis patients, largely in this illegal population. But it also happens in non-illegals. It's just people that don't have good access often get substandard care. Not always. Many systems do a fantastic job caring for undocumented residents. Others don't. So this vascular access problem becomes an issue, and the repeated infections um, become an issue. All right, so there are several different types of there are several diseases that cause chronic kidney failure, and again, the life expectancy or prognosis really depends on what they have. For the patients with diabetes and high blood pressure that are adults, I'm talking about adults here. Kidney failure does happen in kids. It's kind of a special category. Here I'm mainly thinking of adults. Many of these things apply to kids too, but the prognostication is very different. That 5-year window is really that diabetes and high blood pressure kind of patient. And again, those data, depending on the quality of dialysis and the quality of cholesterol control, the quality of blood sugar control, that can be a lot longer than that. But patients with other types of disease may live a lot longer. So a patient with focal segmental glomerulosclerosis, which is a disease that mainly just hits the kidneys, may live 30, 40 years plus. There are 2 famous NBA basketball players that basically had this. This isn't breaking HIPAA. I didn't care for either. It's in the news. So Sean Elliott and Alonzo Mourning, both star NBA players during their era, both diagnosed with focal segmental glomerulosclerosis by my understanding, and both actually had kidney transplant and then returned to the NBA. It was just challenging for a couple of reasons, but they were able to, and they should have fairly normal life expectancy, maybe a little shorter, but we're not talking about 5 years of being ill. Okay, so in these patients with kind of local kidney disease, the prognosis can be much longer. That's the main point I have here. Now, in addition to hemodialysis, there's another type of dialysis called peritoneal dialysis, or PD. Peritoneal dialysis does the same things as hemodialysis. It's just a very different type of methodology. You actually have a catheter that goes into the abdominal cavity, and you're using the lining of the abdominal cavity as that semi-permeable membrane. And so you put fluid into the abdominal cavity. It's not going into your intestines. It's not going into the inside of the intestine. It's bathing the outside of the intestines, bathing the outside of the inside of the abdominal wall. We have, all of us have a potential space. It's not a realized space within our abdominal cavity. And what adding this fluid does is it just fills that potential space. Not with air, but with dialysis fluid, a special peritoneal dialysate. And it works basically the same way. Now, there are differing categories of who is a candidate for peritoneal dialysis. It is far less common in the United States than hemodialysis. And there are some nephrologists that have defended it and tried to make it more common, others that think it's not as helpful. But it is an option that you should realize. It's very common. Matter of fact, almost always when I have a kidney failure patient that we don't know what to do, I often will ask, is the patient a peritoneal dialysis candidate? So one of the ethical issues is center rejection. And one of the questions I come up with, or that I ask, is the patient a peritoneal dialysis candidate? We'll cover this again briefly, and I'll say that one more time. Another treatment is kidney transplantation. I will mention some things on transplant. I mentioned some during lung failure lecture, but also in the guide committee lecture. Kidney transplant is remarkably effective. There are some peculiarities that you should be aware of kidney transplant. One, it's one of the most ethically defensible types of organ transplantation. You can have a kidney transplant from either a cadaveric kidney, but most kidneys now come from living donors. We are given 2 kidneys, and if one wants to donate one of them to help another, you can. So living donor kidney transplantation is fairly common. And some of the questions that have come about, and this is for another course, but I'll just mention them here, is what's the risk of donating a kidney? Well, there is a risk. And some have been critical that we don't share the risk as in the kinds of terms that patients often want. So even though our medical society and the transplant community may accept one level of risk, it doesn't mean that that's the level of risk that the patient, that the donor will accept. And some have criticized transplantation, with kidney transplantation, that we we project our values and our risk assessment onto the patients and don't always emphasize the real health risk. I think that's gotten better. I think some of the health risks are really disclosed. We have noticed that some populations are at greater risk. For instance, African American men are at greater risk if they go through life with a solitary kidney for future kidney disease in that kidney. Matter of fact, African Americans are at greater risk for all types of kidney disease, or many types of kidney disease. I won't say all, but many types of kidney disease. I won't go into why that is, or what parts of Africa may be similar or very different. But that's all very interesting kind of anthropologic medicine. But transplantation is often living donors. You can transplant cadaveric, so many kidneys are harvested from or procured from patients that are brain dead or have donation after cardiac death. Again, the transplant policies are for another course, as most of them aren't what we deal with in most clinical bedside ethics consults. It's more of the boardroom decisions. Transplantation also has a couple other. So transplant once immune regulation medications like cyclosporin became shown efficacy. The success of transplantation, kidney transplantation, was much greater. Which is better, hemodialysis or transplant? Well, in transplant you don't have this 3 days a week. You do have to take medicines. You often do have to have anti-rejection medications. They've gotten a lot better over the years, but they still do lower the immune system some, and make people susceptible to infections and even potentially cancers. But they are much more gentle than they used to be. So lifestyle-wise, generally transplantation. It looks that transplantation is likely working to trend towards a longer prognosis, but this is debatable. For a long time it looked like they were the same. But that was largely because we were dealing with these people with vascular disease. So in the folks with focal kidney disease, it seems that transplant is probably the preference. All right. There's some peculiarities about transplant, though. The Medicare decision to fund hemodialysis just funds hemodialysis. It can fund one can go on the transplant list, and some of the transplant expenses may be covered, but after the transplant, the patient is then dropped from Medicare after a certain amount of time. I think it's just 3 months. That may change. Medicare laws change, so don't take my word for it. Make sure you know the facts if you're doing this consult, and any good kidney nephrology social worker will be able to tell you immediately. So if you get transplant, you lose your Medicare benefits after the transplant. That may be defensible, in that people may be more apt to work and other things and get insurance. If an insurance company has a pre-existing illness clause, they may not want to take transplant patients. But again, those pre-existing illness clauses are becoming less popular. But the ongoing need for anti-rejection medications and regular physician visits is real, and so that is one of the defenses that people that are getting transplant need some sort of income. So those that are jobless or don't have any social support where they can get other sources of income, transplant sometimes can be challenging because the Medicare option, unless someone is disabled or if they're already in the Medicare age, but just getting the Medicare benefit for kidney failure, that may go away. Now, this is an active area of policy reform, so this may change in sometime in the future. It seems that lifelong transplant is probably more affordable. So in many developing countries and developed countries that just don't do dialysis regularly, transplant is the norm and not hemodialysis. I've traveled in parts of Africa, developing countries in Africa like Nigeria and Ethiopia, and it may be possible for a Nigerian or Ethiopian citizen to get a kidney transplant, but they'll never get hemodialysis, at least not that I'm aware of. And that's partly for financial reasons. It's partly just because of the technology that's available. Okay, so now some of the ethical dilemmas that one faces in dealing with kidney failure patients. I'll just erase a few of these, create some room. One of the issues is this issue of futility. So the clinical ethicist often will get a consultation saying the patient is in the ICU, has septic shock, and has kidney failure, and they're on a special type of dialysis, which is continuous dialysis, so sometimes called CVVHD, which is continuous veno-veno hemodialysis. But there's also SLED, which is slow, low efficiency hemodialysis. And all these are changing. The technology is improving, but it's special hemodialysis for very sick patients that have low blood pressure. And the patient has multi-organ system failure. So their kidneys have been affected. They have low blood pressure. So the vascular system has been affected. They may have a large systematic or a large pneumonia that's complex. They may even have had some liver injury. Remember for this recording, so you can see what I write, everything's flipped. So it looks like I'm patting the wrong side, but I'm really patting my right side. I'm just flipped on your screen. So the physicians come to a place where they think, oh, the patient is not going to survive the hospital stay. And so they come to ask, is this a case of futility? Now, futility, if something's futile, it means it doesn't work. But there's really three types of futility that we can distinguish. There is, and this may come up in other sessions as well, there is biological futility or physiologic futility. I usually call it physiologic, by the way. So physiologic futility, there's what we say quantitative or probabilistic futility, and then there is qualitative futility. So the biologic physiologic futility means it doesn't work. It does not work. This is, hey doc, I want chemotherapy to cure my acne or something. No, that just doesn't work that way. Or someone has a non-operable tumor that's around large blood vessels, and they say, I'd rather die on the table than to not try. Well, it's if the surgeons don't think their clinical judgment says this is non-operable, we can't do it. It just doesn't work. It's biologically or physiologically futile. We don't do it. Quantitative or probabilistic futility means, well, though in theory it may work, clinical judgment says it's probably not. And some different authors put different numbers. Some say 1 in 1,000, one say 1 in a million, some say clinical judgment open, maybe 1 in 100. 1 in 1,000 is, if you want to quantify, maybe there. I think it really depends on the circumstance. It depends on the burden of the treatment and many aspects of the treatment. So I don't want to give you a real number. It just means that this is clinical judgment, this is not going to work. Or it's very, very, very unlikely to work. So we can say very unlikely, even though it may be theoretically possible. Right? Qualitative futility is though the treatment is effective, so the treatment effective, is it worthy? So what I mean by that is the treatment may deliver its primary goal. The ventilator may make the lungs go in and out and exchange carbon dioxide and oxygen. The dialysis machine may get rid of the potassium, but is it worthy in this statement, in this way, in this patient, in this context? Should we use it? It's kind of a qualitative judgment. Okay, a lot of authors will not want you to use the word futility anyway. It's the big F word of clinical ethics. I think it's used commonly in medicine, and you can use it. You just have to define it. If you're going to use this you're going to get questions on medical futility if you do clinical ethics consults, and you're going to have policies for your health system on medical futility. If you're in Texas, you even have a law about medical futility. Most other states don't. I'll mention that briefly. Some authors will want to clump, if they're going to use futility language, they may call both of these top categories biomedical futility. This is the domain of medicine. This is the domain of the clinical judgment. The physician can make this evaluation, where this qualitative futility may be a little different. Why on earth am I mentioning this again with dialysis? Well, when you have your neurologic failure patient, or you have that patient in the ICU, you need to distinguish between biomedical futility and qualitative futility. You don't need a hyphen between biomed, by the way. If the patient is not likely to survive the hospital stay and is not tolerating dialysis very well because their blood pressure keeps dropping, or something like that, we may be talking about physiologic futility. If we don't think the patient's going to die despite our best efforts over the coming days, and this is not going to bring healing and recovery, we still may be talking about the probabilistic futility. This is biomedical futility. But if we're talking about a patient who's just had a big stroke and they can't communicate as well as they did before, and they may have one side that's weak, they may have a hemiparesis, we're probably in the realm of qualitative futility. Why is this so crucial? In my judgment, and this is stated in some hospital policies, most laws don't deal with this at all. So we're not in the realm of law. But many authors, and I learned this from Bob Orr, who you're reading, think that the distinction is important, in part because this qualitative assessment is not clearly the domain of medicine, where physicians should not be asked to do medical treatments that don't work. There's no obligation for a physician to do a treatment that doesn't work. But a treatment, not giving a treatment because they don't think it's worthy in this case, is a little shaky. It's a bit shakier ground. So I say that assent, at least, is needed. So we need to get that proxy decision maker usually. We need to get, I say assent instead of consent. I say you can be directive. You can say, we think we're going to stop hemodialysis in your loved one who has had this neurodevastating stroke, because even though it could be given, we don't think it's going to help the final outcome. And this is a big burden to have someone 3 days a week on a dialysis center who is neurocognitively devastated. You can be directive. I wouldn't use the words I just used, but you can be directive. So that degree of direction, I would say it's assent, and that should be two S's. Similar words, but the C means something slightly different. But so assent, an assent-seeking process, you're just giving them the opportunity to say, no, I don't want what you want. But it probably isn't a full consent process in the traditional way where the options are really all being offered more neutrally. I think this is more of assent seeking. If the patient is in the ICU and you think it's biomedical futility, I think you can be more directive. I think physicians and clinical bioethicists, if they believe it's in the biomedical futility category, can say, I'm sorry, we're not going to continue this. Now, that may, if you have a patient who's dying in the ICU and you're on continuous dialysis, how this is communicated is very clear. You don't go, if it's decided that it's biomedical futility, you don't go and say, well, your loved one has kidney failure and they're on dialysis and it's working just fine, but we think this is futile, we're going to stop. Well, that's just foolish. I'm not saying to use rhetoric that will deceive the patient's family. I'm saying think about who's receiving the information. To come and say, I'm so sorry your loved one's so sick, they're dying, it doesn't look like we can do anything to change that. And because of that, some of the medical technologies we're using just aren't helpful any longer. We don't think it's going to change the outcome, and often it's not even going to change the timing much. So back in the paternalistic days of medicine, you would just come in and say, I'm sorry your loved one's dying. We've done all we can do. Sometimes I wish we could do that a little bit more, instead of putting a needless burden on families when there's not an option for healing and recovery. Now, I'm not, I'm opposed to assisted suicide and euthanasia. I don't like the culture of death, all those things. But sometimes we just put a burden on families that they don't need. It's an unnecessary burden. They think that they need to fight for family and they need to make a decision for life and all these things when that decision just isn't there. So I think it's unfair to families sometimes. So with biomedical futility, I don't think you necessarily need that assent process, not based on medical ethics standards. If you don't think it's not going to work, or clinical judgment says it's not going to work, there is no duty to provide the therapy, either from the beginning or once it started. Now, once it started, you may have a higher burden to defend it, but still it can be stopped. So this is an important distinction between this biomedical and qualitative futility. Now, I mentioned Texas. Texas is unique in many ways. As a Texan who now is a missionary to the Yankee in Ohio, Texas has many unique things. One of the things is this, what I'll just say, the law that deals with futility. It's not called futility. It's called inappropriate care. So they deemed that a futile case would be inappropriate medical care. Now, the problem I have, I like the Texas case in that, or the Texas law, in that they try to deal with it. And it's such a common question that they have a process, and the right people help deliberate on this. So all the people doing ethics work and ICU work came together. The genesis of it, my understanding, came from the Texas Medical Center in Houston, a little before I was there. But there was really a legislative movement that flowed out of the medical center saying, help us make these determinations. The law basically says this: if it's deemed by the primary treatment team that someone has a futile case, a medical futility case, or an inappropriate care case, they call an ethics consult. The ethics committee then judges, and they have to have a committee vote. At the hospital I worked in Texas, we did these evaluations, these futility or inappropriate care evaluations in teams of 3. If one of my men, if Engelhardt were here, he would yell at me for saying futility. That's inappropriate care. It's not a futility case, but it is. I think it's both. In my experience, the 3-person team would assess the case and then present it to the full ethics committee. If the patient's family disagrees and is fighting the information that the primary team is saying, and they're saying, no, we don't accept that this is a inappropriate care or futility case, and the ethics team has already communicated that and they still haven't accepted it, they have the ability to go before the ethics committee and give their testimony, basically. In some ways, this makes the ethics committee kind of a quasi-judge and jury. It's a very interesting law in that way. Then if the ethics committee says, no, this is inappropriate care, it's biomedical futility, or it's futility, I shouldn't say biomedical, but futility, then they give a written notice to the patient's family that they have 10 days to find an alternative treatment site, that the technology will be stopped in 10 days. Okay, so that gives at least transparency and a process and procedure. The problem I have with it is, if it's a futility case that's in the biomedical category, why are you going to require 10 days of inappropriate care, really inappropriate care that won't work or is very, very unlikely to work? I don't think we should have any time requirement for that kind of futility. However, that's probably not the majority of cases. In all the cases I was involved in Texas, they were all qualitative cases. So my question with qualitative is, why only 10 days? Maybe it should be longer. What's the hurry? And they did the best. They did what they thought was right when they wrote the law. So that is that. Most states, the Texas futility law has been around since the 1990s, and most states have not tried to do something similar, which is somewhat interesting because most of Texas law is fairly allowing. It's not overly prescriptive or proscriptive. It allows a lot of discretion. So other states are far more prescriptive. Like we had mentioned, many states have in proxy decision making, have a statutory list that you must follow, must go down. But those states that are more prescriptive and proscriptive in the law haven't really dealt with this issue to the same level that Texas, who's more allowing in its law, generally has. So that's interesting that it hasn't caught on. Many predicted that it would pretty quickly. Now, some hospitals have futility procedures within their system, and that may be a better way than having a one-size-fits-all approach at the state level. So that's the main issue with the neurologic, this kind of futility question. It is noted that there are position statements by the kidney disease associations. There's a couple of them that comment on when a nephrologist, a kidney specialist, can refuse to give hemodialysis. And these position statements are updated every so many years. In the past, they have basically said if someone has neurocognitive devastation, then the nephrologist can refuse. Also, if the patient is not, if it's their clinical judgment, this patient is not going to survive, so kind of the biomedical futility, or has terminal illness, think like terminal cancer. Problem with terminal cancer is sometimes dialysis will be helpful. Just because you have terminal cancer doesn't mean you have to die right now from your terminal cancer. And most nephrologists, if they think the cancer could, most nephrologists, if they think the hemodialysis can prolong life and give a chance for longer life and someone is not neurocognitively devastated, they'll often do it. But their position statements do have an allowance often for neurocognitive devastation and terminal illness or very, very, very poor prognosis. Now they're changing. And matter of fact, over the years they've gotten a little more allowing for, or they used to allow physicians to say no, or suggest that physicians should say no more frequently. In my reading of them, they now equivocate just a little bit more. I still think there's a professional standard that allows for a nephrologist to say this patient is not a dialysis candidate. And that's not only a question of whether you can get vascular access or whether their blood pressure can tolerate it or something like that. Often they can say, due to the patient's vast neurodevastation or due to the patient's underlying terminal cancer and their very short prognosis, or due to the other comorbidities in ICU, that they're dying, the patient's not a good dialysis candidate. I think that's defensible. It's not always what happens, though. Just because they can say that doesn't mean they must. All right. So next is what happens when a center rejects a patient who has Medicare, and say the patient has acted out, has psychiatric disease, and has acted out at the center, and they've been fired from that center. Well, often they'll be fired from multiple centers and no one will take them. And this becomes a real quandary. For some hospital systems just say, hey, come be dialyzed at our system. If a region has an indigent care system, often they become the de facto last resort of dialysis. Now, if the patient acts violently or is uncontrolled in some way there, even though those systems are more permissive, they then are just in the same boat as that original dialysis center. And sometimes they have to say, we can't continue to do this. I mean, you could say sedate someone, but when you're sedating someone 3 days a week for multiple hours, that's dangerous and not something that's acceptable. So sometimes the answer is either, are they a peritoneal dialysis candidate? Are they a transplant candidate? But sometimes it's that they're no longer a dialysis candidate, which means that they'll probably die from that disease, which is painful. But if people can't abide by rules that keep all the other patients safe, and if we can't treat psychiatric disease to a level where they can be safe at a dialysis center, then sometimes these bad outcomes do happen. And it's not saying that you don't like the person or that you think they deserve to die or anything like this. It's just saying if you can't keep a dialysis center safe, if you can't treat the patient where they can get the treatment in a responsible way, and sometimes we just don't give the treatment. And that's really hard. Often academic medical centers, we have several of these patients that just stay in the hospital with a sitter, or we try to find some place for them, some placement where they can get some dialysis. But it's very difficult. So there's no duty for a dialysis center to take a patient. If the patient meets their criteria and the patient signs something saying I will abide by the following rules, if they break those rules or they're deemed not safe by acting out in some way, the dialysis center has the ability to exit them, to fire them from that clinic. Academic medical centers then Often these patients are just coming in through the emergency department. This is true for regional hospitals too. And then there's a quandary. When you have patients, either in this category or in this category, with the undocumented resident, with the illegal resident, they don't qualify for Medicare, and they're not, in most locations, they're not going to get a dialysis center placement. Some, they're working, that's worked out. I know some places in the country like Houston and Atlanta, the county system has a dialysis center, but only for a small proportion of those that may need it. But they do have some mechanism for dialysis. And many places, it's the indigent care hospital or the academic medical center that, or the regional hospital, and these people come in either at a scheduled time or when they start feeling sick and they get dialyzed in the emergency department. Okay. Some places, they even try to approximate best practices. They'll put fistulas and grafts in patients that are illegal, even though they don't qualify for an outpatient dialysis center. Interesting. Now, here's my take, both on patients that you can't find a center for and patients that are in the country illegally. This is kind of a controversial take, but hear me all the way through before you judge. I don't often at the board meeting, people will say that EMTALA, that is this law governing emergency care that was really created to stop hospitals from shifting non-resource patients to another hospital. So if you're at the Taj Mahal Private Medical Center and you get a poor person that has no resources, you can't just ship them to the county hospital when they're unstable. So EMTALA laws were really this anti-dumping law that says that whatever emergency department receives a patient has to stabilize them before transfer. Now, so many have said, oh, we can't turn down the patient who comes in with a very high potassium or acid-base abnormality or fluid overload from their kidney failure because it's an emergency situation. And so we must dialyze them. We must admit them to the ICU or admit them to the floor or admit them to our special unit, the fast track dialysis. And the problem, the challenge I have is I don't think that that's an accurate reading of EMTALA. I'm not a lawyer. I'm not giving legal advice here. So if you're going to act on anything I say here, get legal advice from your hospital or health system attorneys. But I don't think, in my reading of EMTALA, I don't think that that is what it says. If I have a patient with terminal cancer who comes in with high calcium, was often a complication of terminal end-stage cancer, and it looks to me that they're dying fairly quickly. I'm not required by EMTALA to treat that high calcium. Okay. Now you may say, well, that's because they have terminal cancer and imminently dying. Fine. Okay. Well, let's consider the next case. If I have a patient from who has come in from Africa, who's in the country illegally because they lied on their visa saying, I don't have any illness, and it turns out they know that they have a large mass, and they know they have cancer, and they were told by by physicians in their country, their home country, to get to America so you can get treatment. So they're in the country illegally, even though they may be on visitor status. By definition, they lied on their visitor visa. And they come to your emergency department on day number 2 that they're there, and they have a cancer that maybe you could do some salvage treatment for, maybe you could do some biologic treatment for, but it's going to cost millions of dollars, hundreds of thousands of dollars, millions of dollars, and your system just is saying we can't afford that. And that patient has high calcium. And if you decide not to treat the cancer, are you obligated to treat the calcium? Probably not. Now, if treating the calcium is going to get you a lot longer life, or weeks more, or anything like that, then fine. But you're not obligated by EMTALA to treat a terminal illness that has no good treatment. Or a terminal illness that the patient doesn't qualify for that treatment. And likewise, if someone doesn't qualify for outpatient dialysis, for ongoing chronic dialysis, either because they're in the country illegally or because there is no center to take them, I don't think EMTALA requires that you give them emergent dialysis. Okay. Well, now before you get your dander up, it doesn't mean I don't think you should do it. It's just I don't think EMTALA requires it. So I make this strong, in the systems I've worked with, I've said, let's not base it on EMTALA. Let's not base it on some professional duty either. If we're a system that is built to provide care for a certain type of patient, usually it's not this, especially undocumented residents. I don't know many systems that say that is who we're caring for. I know a couple of medical missions that do in certain cities in the U.S. But as hospital systems, often that's not our mission. And I don't think there's a professional duty necessarily that's agreed upon to treat patients that either can't be treated at a center for various reasons. I do think it's charity care. Now, I don't think charity is a bad word. I think charity is a virtuous word. We'll talk about this kind of policy more in clinical ethics too, but I think it's a charity decision. And charity decisions are difficult. I mean, you have to have the ability to provide the charity, and it needs to be successful. In some of these center rejection cases, it may not be successful because they may not be safe at your location. Often the undocumented resident, it is successful. It can be successful, and it's what can your system provide, whether that be transplant or peritoneal dialysis or hemodialysis, and how to do it in a responsible way. I think we're probably maximizing inefficiency in some of the ways that we give dialysis. Used to be patients, especially the illegal patients, would come in when they're only sick and their life expectancy was short and they were getting very bad dialysis. Getting dialysis only when you're sick is not good dialysis. Now, many centers, especially those centers with a large proportion of undocumented residents, I'm thinking of Houston and other places like that, have, I think, really improved their care of these folks, and they have some data that's coming out over the coming years showing that. I'm very interested to watch their lead. In Columbus, Ohio, we have cases of all these, but often there's an ability for charity, but that may be exhausted at some point in time. It's just our numbers aren't as great as the Harris County Hospital District in the Houston, Texas area, or Bexar County in Texas, or other places in the country in Southern California or in Atlanta, places like that. The last thing I'll mention is somewhat related, only that it deals with vascular access. Patients on hemodialysis require vascular access. If someone is addicted to drugs and has especially a history of IV drug abuse or potential for IV drug abuse, it's very difficult for us to give them vascular access. The grafts and fistulas often will be infected by the IV drug use. Now, some people say, well, just give them clean needles. But also patients with vascular disease the illegal drugs can be very, very bad for their body. And many nephrologists just don't want to participate in giving IV drug abusers a central access so they can feed their addiction. I say my view is when someone has known addiction or diversion, that is a problem that is on par with their primary illness, whether that be cancer, or whether that be cancer and addiction, or kidney failure and addiction. I think it should be taken at least on par. Sometimes it should be even greater. I run a palliative care clinic or supportive oncology clinic, and when I have patients with even terminal cancer and drug addiction, I treat them on the same level. If we're working with addiction and we're trying to stay clean and we're doing all the responsible things, and then probably the patient may be prescribed opioids in an appropriate manner. But if there's urine drug screens that are off, or some other suspicions, then often, even though they have terminal cancer, doesn't mean that we ignore this addiction issue, which is as big of an issue as their kidney disease. So sometimes drug abuse can make a patient not a dialysis candidate or a transplant candidate, and it does increase infection for these fistulas, which sometimes is one of the causes of death, and get you into that futility category. Okay. So kidney failure is a common consult for various reasons. Maybe futility, maybe what do I do with this patient that has these major social problems. Often this kind of patient can be dealt with at the boardroom level when you get good people together to think about the kind of preferred guidelines and patterns. Now, they'll still get these dilemmas at the bedside, and each case should be taken with its peculiar distinctiveness, but this is something you can think about in advance as a system. I think we've covered enough for this course, and I look forward to next sessions.